Hey, my name is Jeffrey Ross. I am interim dean and professor of nursing at Abraham Baldwin Agricultural College, and today I want to discuss prostate health with you. Since 1999, September has been recognized as National Prostate Awareness Month. In this month, health professionals, researchers, survivors, and even family members take special efforts to increase public knowledge, promote screening, increase education, and support research regarding prostate health. It's no surprise that prostate issues arise within males, so I want to kind of explore that a little bit with you today, specifically looking at some pathophysiology, the signs and symptoms that you would expect to see, and nursing management. We're also going to talk about some of the psychosocial and emotional implications related to prostate disorders. So, this is the male reproductive system. Most people are familiar with the reproductive system from males. Um, but what I've noticed throughout the years is, as far as students go, students never really understand what the prostate is. I've even had a couple of students say to me, I didn't even know I had a prostate. So, um, suffice to say, women do not have prostate glands. Only males have prostate glands. So, what is the prostate? Well, the prostate itself is an accessory gland that's a part of the male reproductive system. It's found below the bladder. It's around the size of a walnut. Some references will tell you the size of a golf ball. The problem with the prostate is that anatomically the urethra passes directly through the prostate. So, what you wind up with if you do have prostate problems are problems associated with urination. Prostate is located just below the urinary bladder, and it's responsible for producing and storing fluid that forms part of semen. Semen, of course, being the substance that's emitted during ejaculation as part of the male sexual response. Prostate fluid is slightly alkaline. It's milky. It's kind of white in appearance. The alkalinity of the semen helps neutralize the acidity of the vaginal tract, which is going to prolong the life of sperm. Usually, prostate fluid is expelled in the first part of the ejaculate together with most of the sperm because of the action of the smooth muscles tissue within that prostate. So, why are we discussing prostate health? Why is this important? It's important because 50% of men over the age of 48 wind up having some type of prostate issue, whether it be prostate cancer or whether it be benign prostatic hyperplasia. 90% of people, of males over the age of 80, develop some form of prostate issue throughout their lives. Most common disorder is going to be BPH. BPH is benign prostatic hyperplasia. It is a common and it's an age related syndrome. So, the term hyperplasia simply means that you have an increase in the number of cells. Now, BPH is non malignant, but it is an enlargement of the prostate gland. And the reason that a person has that enlargement is usually due to hormones. So let's talk about that for just a minute. The person has to be older than 48 and they have to have the presence of testicles. So, prostate enlargement depends on basically the what are referred to as androgens within the male's body. Androgens are male sex hormones. So it's androgens such as DHT, testosterone, that actually causes the issue with BPH. Okay, so in the prostate gland itself, you have what is referred to as a type 2,5 alpha reductase that actually helps to convert testosterone into DHT. It is that DHT that actually causes the problems within the prostate as far as hyperplasia and enlargement. Okay, so essentially, it's hormone driven. Now there are risk factors associated with this, such as aging, family history, more common in African Americans than in Japanese Americans. And there has also been some research that has shown that people who have diets that are higher in meats and higher in fats actually develop problems with the prostate more frequently. Looking at the picture on the slide, you'll see that you've got a normal bladder, a normal prostate on the left-hand side, and on the right-hand side is the person that has actual BPH. So you've got expanding prostatic tissue in this area. You also have an increase in the muscle lining around the bladder. That's to kind of help push through and actually get that urine to move past that compression there. This is the problem. This can actually cause a partial or it could cause a complete obstruction of the urinary tract itself. So if somebody develops problems with the prostate gland, they typically present with either obstructive or irritative forms of um, BPH. Most common is obstructive. Like we just talked about, you either have a partial or it's a complete obstruction. That causes pressure actually on the urethra itself. So that's where the term obstructive comes from. It's that pressure that's there. It causes that urinary system to not be able to function like it's supposed to. So males will have a very weak urinary stream. They will have problems starting urination. They will have problems emptying their bladder and even have some post-void dribbling behind it. Um, on the flip side would be irritative or irritational in some references. This is simply bladder irritation, okay, and it comes about from retention of urine. Um, so that urine that's actually not being expelled can actually cause you to have bladder irritation, can cause you to have some discomfort during urination because your body knows that that urine's not supposed to be in there. You have an increase in frequency, you have an increase in urgency. Associated more commonly with irritative is things like infections. Um, but if we kind of go back, let's kind of go back and look at this picture again. So this is showing you urine that's actually there. Okay, here's part of the problem with this. If that bladder does not empty, that urine continues to rise. Okay, it is possible for that bladder to get so full that that urine actually return into the ureter. So that person can actually develop what's referred to as hydroureter. If the bladder is not emptying, but yet you're continuing to drink and you're continuing to actually make urine, that urine's got to go somewhere. So it goes upwards. So they can develop hydroureter, they can develop hydronephrosis, where the kidney itself actually begins to swell because of excess urine. You can also see renal insufficiency. There's also a form of acute renal failure that somebody can go into just because of the prostate not being able to actually um, be emptied, emptying that bladder like you're supposed to. So, how is it diagnosed? Well, it's diagnosed through a digital rectal exam. So, of course, the physician or the nurse practitioner or PA, they actually would do a digital rectal exam to assess to see if the prostate is actually enlarged. A lot of times what they find is that it would be enlarged and it would be asymmetrical in shape. Um, you also see the use of PSA levels, which we'll talk about when we get to prostate cancer. You also have to look at, on your physical exam, you have to look to see if you do notice that there's prostate enlargement. You probably want to do like an in and out catheter just to measure residual urine. If you get residual urine greater than 100 milliliters, that's considered to be very high. So that's considered that we need actually are going to have to do something about that to give them some relief. You also see urinalyses that are ordered looking for white blood cells, red blood cells. It's not uncommon too for you to go ahead and assess your creatinine levels, to assess your BUN levels, to see exactly what kind of read you're going to get from those labs. If we do have an issue with our prostate gland, one of the things that your very first line of defense is going to be some type of medication therapy. Uh, so let's talk about this for just a minute. You have two classes here. You have the anti-androgen agents and you have the alpha adrenergic antagonists. Hyperplastic tissue, or BPH, like we talked about, is androgen dependent. Okay, so remember we talked about the conversion of DHT and actually having that tissue at that prostate gland to be dependent upon that. So the very first thing you see used is 5A reductase inhibitors. So when we talked a while ago, we said that testosterone is converted to DHT through an enzyme called 5A reductase. Well, this is 5A reductase inhibitors. So what this does is it's actually going to inhibit the conversion of testosterone to DHT. Because the prostate gland tissue is dependent upon androgens, if we remove the androgens from the surface, we should see a decrease in the size of our prostate. With a decrease in the size of your prostate, you should also see an increase in urination, those types of things. So example of that would be Avodart. The next one that's on there is your alpha adrenergic antagonist. So smooth muscle contraction within that prostate can actually exacerbate urinary retention, making it harder for that bladder to actually empty in addition to the hyperplastic tissue that's there. So alpha adrenergic antagonists are actually going to relieve the obstruction and increase the flow of urine by relaxing those smooth muscles. So things like Flomax, just like the name says, Flomax, it makes you have maximum outflow of urine. Um, so what research has shown is that both the use of antiandrogens and alpha adrenergic antagonists together seems to be more effective than just using one or the other. Now, if you do have patients that don't really want to take take prescription meds or what we refer to as Western medications, phylotherapy is one that you can actually do with them. Phytotherapy is the use of herbal medications. Most people are familiar with saw palmetto. You also have purpurea, the leaves of the trembling poplar. All of those things actually help to alleviate irritation, but also help that prostate actually not be as large as it is. Um, there are several different BPH treatments besides medications. So you've got several different options as far as this goes. Uh, a couple of them that are at the top, the microwave thermotherapy, that's when they actually use microwaves to basically heat and destroy prostate tissue, just like your microwave at home. It actually will heat and destroy that prostate tissue, which should help eliminate some of those urinary signs and symptoms you've got. You also see the transurethral needle ablation. Now that's when you actually use low level of radio frequencies through needles to actually burn away regions of the enlarged prostate. Again, helping to actually open up that area. The same concept with the transurethral incision. You actually incise and remove a portion of the prostate, not the entire prostate, but you actually remove a portion of that prostate to eliminate some of your signs and symptoms of urinary frequency. Open prostatectomy, laser surgery, both of those actually would remove the prostate itself. You also may see a balloon ureteroplasty used, where they actually would insert a balloon to actually, which is what this is showing here. It's essentially a catheter that expands, and it should actually blow up inside of the urethra to actually allow expansion of the urethra against the prostate walls. You can then put an actual stent in there. On this next slide, this actually is showing you a prostatectomy. So this is a retropubic prostatectomy. So this is typically done for people who have really large prostates that you can't really remove through the transurethral approach. More common is your transurethral resection of the prostate, or what we refer to as a TURP. So this is one that is more common within your hospital settings, more common within treatment options here. Associated with quite a few complications that go along with this, but for the most part, this is a relatively safe procedure for most males. Um, with the actual TURP itself, you see on the slide, this is actually how the TURP is performed, but you actually have a retroscope that's actually inserted into the urethra, It's advanced to the prostate area. The prostate tissue is then removed, and any excess tissue like that is flushed back into the bladder itself, and then you actually flush or irrigate it out with fluid at the end of the procedure. And one of the things that nurses are responsible for following the TURP is to regulate your continuous bladder irrigation. And that's what we talk about in just a minute. But whenever you're dealing with nursing care and you're dealing with BPH, you really have to talk to your patients about what are their signs and symptoms that they're actually experiencing. Talk to them about what the prostate typically does under normal conditions and kind of link that back to what they're experiencing right now. If the physician has discussed treatment options with them, of course you can go in and kind of get an understanding of what they know about the options that they have available. You also will see the need to talk about Kegel exercises, teaching them to start and stop urination to help build the Kegel exercises, um, monitoring intake and output, those types of things. In the postoperative period following your TURP, that's really where nursing really comes alive and kind of really has to pay attention to that. So they come back typically with a continuous bladder irrigation. Continuous bladder irrigation, also referred to as a CBI. So a CBI is basically an 18 to a 20 gauge French three-way catheter that's inserted. It's usually secured with either a 30 or a 45 milliliter balloon. So this is a large catheter that's placed in a very large balloon is actually used for it. On the slide, you see you have three ports. You've got one for your irrigation, or excuse me, yeah, one for your irrigation, one for your balloon inflation, and then one for your actual drainage. So it's a three-way catheter, 1, 2, 3, that you're dealing with. Okay, so why would a person come back with a CBI? Well, the purpose of the CBI is to prevent formation of blood clots. It's to help flush out any excess tissue that could be there. Um, So the purpose is to irrigate it. How do you irrigate? Well, you have to titrate the flow to maintain your outflow in a light pink color. In the very early stages, we want it in a very light pink color. As that fluid begins to irrigate and actually rinse out that bladder, you'll actually see later on, you will start producing just more pale, what looks like and actually is pale colored urine that's there. But our big thing here is to prevent blood clots from actually forming. That's the purpose of this CBI, is to keep that area flushed out. It helps to prevent any kind of hemorrhage. Now, if you do experience some kind of blood clot, you can go ahead and irrigate it with a 50 milliliter bolus, if you will, to kind of rinse out that area. If you allow your irrigation solution to run dry, then you most assuredly are going to have some type of plugged or you know non-patent catheter anymore. And of course, you're going to get in trouble with that because the physician's not going to like you very much because you've let his work kind of or her work kind of go down south. But with this, you have to make sure that you're monitoring for what's referred to as TERP syndrome. TERP syndrome is when the person actually begins to absorb the irrigate fluid that you're using. Um, that causes them to have a reduction in their hematocrit. It causes them to actually have hypertension, bradycardia. So it results from absorbing those irrigating fluids, and it essentially just puts them into fluid volume excess. So you have to really pay close attention to your vital signs following it. You're also observing for hemorrhage. You're making sure that you talk to them about if they feel lightheaded. You're monitoring for tachycardia versus hypotension. You may actually have to elevate the scrotum and apply ice. When I take care of patients that have TERPs, one of the big things is bladder spasms. If you run your irrigation fluid too quickly, you cause the walls of the actual bladder to be rinsed out too fast, and it actually causes those bladder spasms to actually take place. Um, so you have to be careful about regulating it and titrating it. It can take a while sometimes to actually get that titration to work. But um, once you get it regulated, as long as they don't complain of bladder spasms, you're pretty much okay to just let it go as it is. Whenever you do have to change the irrigation bags or whenever you're irrigating the Foley itself, make sure that you are maintaining sterile technique. You are assessing urine output at least every 1 to 2 hours. And one of the things that a lot of people don't actually think about is we do have to monitor intake and output, but we are actually putting that irrigant is actually being introduced into the body. So the way you have to do this is you have to subtract your CBI inflow from your actual output for that shift or for the 24-hour period. So once you actually subtract those two, that's how you determine how much actual urine output that person had. So it's the same concept of like other type things. You want to have at least a minimum of 30 milliliters an hour of output. If not, you of course want to make sure that you report that to the physician. You also have to document the size of the catheter, the size of the balloon that's there. Teach your patients too not to strain, because sometimes they'll say I've got to urinate and they'll try to actually strain around that catheter, which is going to cause you to have more bladder spasms, and it can actually cause them to bleed in some cases. So that's your looking at your CBI. This is just another showing of a picture here that the students actually like most of the time. It kind of helps them give a visual as to what they're looking at. Um, but again, other things that I didn't necessarily speak about just then was the actual infections, prevention of DVTs, because they are actually in the bed. We have to make sure that we're giving them low dose heparin, Lovenox, something along those lines, compression stockings, TED hose, um, SCDs, anything along those lines to kind of help prevent any kind of DVT from forming. Post-op, you have to spend time talking to your patients about um, erectile dysfunction. Okay, so erectile dysfunction meaning that they're actually able either not to obtain an erection or not to maintain an erection. And a lot of times that's a very, very, very sensitive topic for men to discuss because, I mean, let's face it, it makes them feel like that they're actually less of a man if they can't actually have an erection. Um, what I found throughout the years is it's kind of backwards for me, but what I found throughout the years is men are more likely to discuss erectile dysfunction with a female nurse than they are with a male nurse. Um, I would think that it would be harder to discuss that with a female nurse, but not with patients. And I guess I can understand it too because there again, if you're doing male to male, then you don't want to admit that you're not having erections and those types of things to another male. But so talk to them about erectile dysfunction. One of the things you also have to look at is how do they understand the whole incontinence issue. So some of your patients that you have that have a TERP and wind up actually having to have their prostate removed, they actually do develop incontinence. That incontinence can last for several days. It can actually last up to 2 weeks. It can actually last up to 2 years in some people. So you want to make sure that in that refractory post-op that you do talk to them about urinary continence. And they may actually wind up having some type of device installed to actually prevent incontinence. Lastly is prostate cancer. Now, prostate cancer is an unknown origins, but again, it is linked back to androgens. Most people who develop prostate cancer have some type of genetic or family history of it. Um, there are studies that say diets higher in animal fats can actually contribute to prostate cancer. But this is the most common type of cancer in men, and of course, if second to heart disease, cancer in general is just the second leading cause of death in North America. Um, Usually curable if it's detected early enough. So you can actually detect it early. You do have a better chance of actually um, beating the disease process. In fact, recent studies show that men who are diagnosed before metastasis occurs have nearly 100% 5-year survival rate and a 98% 10-year survival rate. However, if it's not detected earlier and it spreads to other areas of the body, you only have a 30% chance of a 5-year survival rate. So early detection is very important, thus Prostate Health, Prostate Cancer Awareness Month being in September. So as far as patho goes, this is an adenocarcinoma, and anytime you see the term adenocarcinoma, that just means that it's a cancer that lines the actual cell lining of glandular organs. It's really all that's referring to. But um, it does seem to develop, as you see on the picture, in the peripheral zones of the actual prostate itself. It can actually metabolize directly to things like your seminal vesicles or to the bladder itself, and it can also metabolize by the lymph and the blood. So it actually does have a way to move. Most men become to the physician's office that are asymptomatic early on. Sometimes it's found whenever they develop urinary manifestations like BPH, like hesitancy, urgency, the dribbling of the urine that we talked about. Some men notice that they have actual blood or urine in their ejaculate, or blood in their urine itself, or they may actually present with bone pain. And usually bone pain just means that they actually do have metastasis at that point. Your signs and symptoms for prostate cancer are going to depend upon the size and the location of the tumor and the staging of the malignancy itself. Of course, stage 1 would be easier to treat than stage 4. Um, how do you actually diagnose someone as having prostate cancer? Well, the only definitive diagnosis is to do a biopsy. And usually what you will find on physical examination is a nodular fixed gland that doesn't move. It stays in that one position. You also will see elevations in your PSA levels. Okay, so PSA meaning prostate stimulating antigen. So PSA levels, they tell you the number of well, essentially the number of the PSA, but what I was going to say is PSA itself is an enzyme that's produced exclusively by your prostate cells. So when you do a PSA level, that's actually going to tell you what that current capability of producing that enzyme is. Most of your references and stuff tell you there is no normal range for a PSA level. Most of them will tell you that there's what's referred to as a safe range. So a PSA between 0 and 2.5 is considered to be safe. A PSA level that is less than 4 is considered to be safe for most people. There may be some that have problems with it, but for most people, a 4 or less is what we consider to be within the safe range. If somebody develops a PSA level that's 4 to 10, they have about a 25% chance of having prostate cancer. And if it's 10 or above, it's usually like a 50% chance of prostate cancer. I took care of a patient one time with hospice. He had a PSA level that was 15,000 when we first admitted him, and then of course as his disease progressed, kind of got worse and worse. It actually went up to like 22,000, I think it was. Just really huge numbers that tied back to that prostate cancer that he had. Transrectal ultrasound is when you actually put a probe in the rectum and you actually look at the prostate itself. You see on the slide you've got a digital rectal exam down here. Again, that's going to show you that nodular fixed gland. If they have bone pain, you're going to see bone scans, MRI, CTs, those types of things. As far as your treatment option goes, radiation therapy seems to really work. But again, your treatment is going to depend on the grade and the stage of the cancer. It's also going to depend upon the age, the general health, and your preference of your patient itself. You typically will see radiation therapy used, and I included the radioactive seeds. Those radioactive seeds can actually be placed within the prostate tissue itself to provide direct radiation therapy to that region. just to kind of give you an idea as to what size we're talking about, these are the little radium seeds versus an actual base of a penny. The other thing is you're going to do androgen deprivation. So just like we talked about earlier with BPH, many cells are androgen dependent. So we can either do hormonal manipulation, which means we're going to do medicine to kind of lower those androgen levels, or you can actually do androgen deprivation in the form of an orchiectomy, which means to remove both testicles. At the beginning of the discussion, we talked about how the person had to be 48 years old and they had to have actual testicles to wind up having prostate issues. So an orchiectomy or removal of those testicles may actually be a treatment that they would have to have. Again, it just depends upon the actual person and what they're facing. Surgery typically means that the prostate has to be removed, and it's a prostatectomy, and there's several different ways you can do that, but um, the prostate typically has to be removed in those cases. Um, I read an article recently that said men, of course, who are eunuchs who have had their testicles removed, or maybe they had maybe they had testicular cancer when they were younger and they had to have their testicles removed. Their PSA levels are very, very low, um, of course, and that would make sense because it's androgen dependent. So, urinary continence again, erectile dysfunction. Most patients experience erectile dysfunction following treatment of prostate cancer. Um, some people wind up having erectile dysfunction for the first 3 months. It could actually be up to 2 years after having the prostate removed. They can experience erectile dysfunction. Those types of things like that is something that we as nurses have to make sure we discuss with our patients. And you want to do that in a professional manner. I always tell the students to make sure you first assess what kind of knowledge base people have. I know one of the things that annoys me the most is when a nurse, because most of the time I don't tell people I'm a nurse if I'm in the doctor's office or having a procedure or anything like that done. I usually don't say anything about it, but is when a nurse comes in and they just degrade you and talk down to you. Um, this is a needle. It's going to give you an injection. And I'm like, really? You're talking to me like that? But so just be mindful of the way that you actually talk to patients. Get an understanding first of what is their knowledge base. What do they actually understand about the disease process before you kind of take off and teach in that manner. Other things would be acute pain versus chronic pain. Um, you have to make sure that they understand treatment options. That some people don't like to take meds, and that's okay. So sitz baths may actually be an option for them. They may wind up having to go to pain management if it's a chronic, pain type situation that they're dealing with. Um, Other things as far as incontinence goes, sometimes you can actually have an artificial sphincter surgically implanted, and that's what this is actually showing you here as far as your pump and your balloon. That would actually help to allow the person to have control. Uh, in order for this to take place, somebody has to be able to physically manipulate that pump and also have cognition enough. So usually if somebody has, for instance, Alzheimer's disease, this wouldn't be an option for them because they wouldn't really remember to actually be able to do this. But um, what happens is you have a fluid-filled cuff that closes the urethra itself. To, to void the bladder pump is squeezed. It draws fluid from the cuff into the balloon, and urine drains through the open urethra, which is what this is showing you here. After voiding, fluid drains back to the cuff, and it actually closes the urethra off. So that actually would help with some of the incontinence issues that males face. Again, this could happen, I mean, minimum of 2 months, but it could be up to 2 years following that. As far as your nursing care goes, identify risk factors for prostate cancer. Utilize the month of September to really, for you as a nurse, to get in there and actually look at the research to figure out exactly what most people wind up developing prostate cancer. Is it only genetics? Where are their risk factors coming from? Is it diet? Is it environment? Um, Very important for you to provide holistic, sensitive, and individualized care. So when you discuss issues of male health or men's reproductive system, make sure you use the actual proper terms. Don't go in saying, using any kind of slang terms. It's a penis. It's okay for you to call it a penis. So if a patient uses a different terminology that you're not familiar with, make sure you get them to kind of clarify what that means. Um, if you're not familiar with it, Kegel exercises need to be taught. Males are taught Kegel exercises by starting and stopping their stream of urine. Um, Teaching methods to control dampness, which includes the use of absorbent pads, but it does not mean to decrease fluid. They need actual fluids. So don't restrict fluids. Have them actually drink more fluids to help kind of provide the additional fluid support that the body needs. Assess pre-treatment sexual function. If they had erectile dysfunction before they had any kind of treatment for prostate cancer, they're most likely going to have it afterwards. Um, but at least you would have an assessment of where they were before. So other things would be like referring them to sexual counseling if they need it. We mentioned pain, those types of things. Okay, so I just wanted to spend a few minutes today just discussing some issues of prostate, and hopefully you got something that you could take away and use. Um, I appreciate you listening, and if you have any questions, please let me know.